All right, let me share my screen. Anybody see my screen? Are we good to go? Can anybody see my screen? Okay, thank you, thank you. Perfect. All right, good. We're fired up. I feel you guys are energized. That's perfect. Okay, so let's explain something. The kidney. So the kidney itself has many different types of physiological function. We talked about this recently. We were talking about renal function. I have mnemonic here, heme. Homeostasis, excretory type of function, especially when it comes to metabolizing certain type of drugs, getting rid of it. A lot of the hydrosoluble type of drugs, you'll see they'll get processed in the kidney. Okay. Many antibiotics, especially. But it also has metabolic function. Remember that the kidney itself, it's something that can perform gluconeogenesis. So gluconeogenesis, it's not only the liver. Keep that in mind. There's many different tissues that can perform gluconeogenesis. So we have a mnemonic for these type of tissue. I'll tell you one thing. These organ systems, let's say, that are able to perform gluconeogenesis, they typically like to use GLUT2. So GLUT2, glucose transporter 2 channel. Think about 2 because 2 means that glucose can go both ways. It can go inside the same way it can go outside. So GLUT2, right, guys? That makes sense. But we had this mnemonic. The mnemonic is clip. Yes, that's simple. Nothing crazy. Just straight up clip. So let me get this for you. Clip is, write it down here. Whoa. CLIP. These are basically systems. I'm gonna call it systems that are able to use GLUT2 expression. And so we have the pancreas, the intestines, small intestines to be exact, actually, small intestines. We have the liver and kidneys. So let's remember that, everybody. This basically is using GLUT2. All right. And yes, these are, you're going to see that that's a very important metabolic function that the actual renal system has. And then you have endocrine function. So let's recall endocrine function. Remember that the parenchyma cells, they're sensitive to hypoxia. They're sensitive to hypoxia. They have a whole system inside these type of cells. This system, it's all about something called hypoxia-inducing factor. So I'll just be very clear with this. Hypoxia-inducing factor, whenever this is increased, you'll have more transcription of mRNA, which will pertain to basically promoting the transcription of EPO. So EPO is synthesized in this way. Hypoxia-inducing factor. This is a weird mechanism. So let's understand this. This is a mechanism that you'll see. It's a very, very important mechanism that has to do with proteasomes. So let's understand how proteasomes typically work inside the cell. Yes, they can be used to regulate certain types of functions like we're looking at now. Imagine the kidney cells, right? They have this type of protein called HIF. HIF is under severe control, is modulated. It's modulated, HIF. If HIF becomes free, it starts to promote the transcription of mRNA, which can code for EPO. So how do we control HIF? How do we make sure that HIF is not expressing itself? We have something called ubiquitin. It's a ubiquitosome, basically. It's a ubiquitosome. It's able to basically cause ubiquination. Let's remember, guys, what is ubiquination? When proteins are taking too long, when they're proteins that should have been destroyed, when they're proteins that are past their time, let's say, they're lingering inside the cell. If they linger inside the cell, they tend to get tagged. They have to get tagged. And this is a process called ubiquination. It's dependent on ATP. So you do need energy for this. When you tag the protein, You're just letting the cell know, hey, this guy is ready. This guy's ready to get destroyed. So proteasomes can sense any type of protein that has been tagged by ubiquitin. And what does it do? It basically stays true to its word. It grabs this protein and breaks it apart to small fragments, small peptide fragments. That's what proteasome can do. Proteasome. Very important function here. Not only is this function important in the, let's say, the maintenance of the cells, but it also has a very important function when it comes to immunology. Also has a very important function when it comes to immunology. So what do I mean? Imagine that a virus is going to attack one of our normal cells, not our antigen presenting cells, but one of our normal cells, right? Just one of these nucleated cells getting attacked by a virus. Now, in order for a virus to actually target one of our cells specifically, it needs to have tropism. That just means like affinity. The virus itself will have affinity for that type of tissue. So, like COVID, for example, had tropism to cells in the lungs. It uses it finds those cells with ACE. It's able to localize it with ACE. It uses that protein specifically to increase tropism towards that type of tissue. So typically, when we look at a virus, we see that virus can have envelope, which can influence the tropism. It has capsid, which will be immunogenic when our immune system is responding to a virus. It's responding to the capsid. And then it also has genetic material, which can be DNA, RNA, single strand, helical, whatever the virus is. So, with that being said, this cell, let's say, has tropism to, I don't know, the lungs. It comes in, it starts to get detected, right? And what ends up happening is that it will get processed by proteasome. So let's say proteasome took on these proteins that were part of this virus, of this viron, and destroyed it. It made peptide fragments. But look how important proteasome is. These peptide fragments are able to enter the rough endoplasmic reticulum. They need a specific type of channel called TAP. TAP proteins are able to allow it to enter the rough endoplasmic reticulum. So once these fragments enter here, they're going to associate with MHC1. MHC1. Now, this is going to form a complex where MHC1 will now have the information of that destroyed, that fragmented virus. The identity is now exposed. So this MHC1 needs to make its way to the membrane. It can do this when it interacts with Golgi apparatus. Golgi apparatus will tag this complex and send it over to the membrane. So then this cell will have MHC1 with the expressed identity of that virus. Expressed identity of the virus. Where now our CD8 cytotoxic cells, CD8 cytotoxic cells, will basically have affinity for this MHC1. Remember that CD8 cytotoxic T cells can promote the extrinsic pathway when it comes to apoptosis, right? It can stimulate granzymes, perforin. It can actually activate caspases inside the cell in order to promote apoptosis, which is the best thing it can do. Because at this point, the cell has replication of many, many different types of virus strains. The virus just keeps on replicating. That's what the viruses do, right? They just want to multiply. They don't care about maintaining the cell. They're not parasites. They just want to multiply, and eventually the cell gets destroyed and they move on to the next cell. Okay, I just explained to you the immunogenic function and how proteasome can do this. Now let's link this back to what I was talking about originally. You're seeing how this one concept, especially for this exam, you'll see that there's certain types of concepts that connect to other things. So right now we're talking about this ubiquination and the role that proteasome plays inside the cell, how it's able to not only work as a maintenance worker, like a janitor, cleaning up any kind of old proteins that are lingering. But it also has an immunogenic response, a very important immunogenic response, in order to allow for the expression of MHC1 in the membrane. So, okay, that's perfect. Going back to the story, we were talking about the kidney and how is it that kidneys can express EPO? Well, I told you that under normal conditions, there's a very specific protein called HIF. HIF is actually being tagged. It's going to get tagged all the time by a ubiquitin. It's going to be tagged by a ubiquitin at all times, just to let it know, hey, you are tagged for destruction. We do not need you at this moment. You should not be trying to code for EPO because we have oxygen. So it has a ubiquitin, E3 ubiquitination. So I'm going to let you in on a little secret. This ubiquitin, it really has a name. It's called VHL protein. Von Hippel-Lindau. Von Hippel-Lindau protein. So this is the job, basically, of von Hippel-Lindau protein to consistently ubiquinate HIF. So HIF will not express itself. Now, in moments where you have hypoxia, where hypoxia occurs, you will find that this VHL loses its expression. It cannot express itself. Therefore, it is not tagging the HIF. HIF is going along without being tagged. If that's the case, now HIF will be liberated. And we mentioned it before. HIF, what does it actually do? Well, when HIF increases, it's able to enhance transcription of EPO. So HIF, remember how this happens. We have our nucleus. Well, inside our nucleus, we'll have our DNA structure. Our DNA can express a specific type of region for transcription, either because you are eliminating the enhancers that surround it, or because you are I said eliminating the enhancers. Quite the opposite. Eliminating the silencers. Remember, a specific gene can be modulated, controlled, either by silencers, which are basically not allowing it to express itself. There's also, you can call those repressors, right? Repressors. We saw that in the Lac-Apron system. So we have repressors, silencers. But you also have enhancers, which will enhance its structure, basically allowing it to manifest itself. And I keep saying it. What am I talking about? I'm talking about the promoter region. The promoter region. Promoter region will always be right next to areas that are rich in TA and TA. There's Tata box, there's cat box, different areas. Why so much TA? Why is that so important? Well, because TA tends to have weaker bonds in comparison to C and G, with cytosine and guanine. You'll see that these have triple bonds. They hold to each other very tightly. T and A only have two. So it's easier to unwind. So yes, the promoter region is basically expressing itself when it is enhanced. So HIF is allowing this to happen. Now that this is enhanced, it's there, it's open, it's showing itself off, you need to have a transcription factor. So let's be clear, guys. It's not only just the idea of having some genes express itself, you also have to have transcription factor. Transcription factors can be stimulated by different things. Many times, you'll notice that transcription factors come from the stimulation of the second messenger system. There's many different types of second messenger systems. But, for example, one of my favorite that I like to explain is the idea of TSH. It's so interesting to me because TRH likes to use GQ as a second messenger system. TSH likes to use GS. And then T3 and T4 are actually intercellular receptors. So they're all having different mechanisms. So it's so interesting in that sense. But before I go into that rabbit hole, let me just finish telling you. Transcription factors are able to bind the promoter region. They're binding the promoter region, right? allowing us to know where this all starts. In DNA replication, we have primers. We have little pieces of information that attach itself to the origin, to where it all starts. Not this. Not this. This is different. This is just telling us, hey, we are transcription factors. We are here waiting for what? For an RNA polymerase. They're waiting for RNA polymerase because RNA polymerase is responsible for transcribing that genetic code that we need in order to make the mRNA for, anybody remember? mRNA for EPO. For EPO. So transcription, okay, so coming from the top, HIF. HIF is usually under control because of ubiquination. It's ubiquinated all times. That ubiquination property comes from a protein called VHL. VHL. It's binding to the HIF. But in moments of hypoxia, this VHL is not expressed. Therefore, HIF is liberated. It starts to increase. And when it increases, it's able to enhance the promoter region. It's able to promote transcription factors, which will bind to this region. What happens next is we have RNA. We have DNA-dependent RNA polymerase. Yes, this is what we have. So let's be clear. For eukaryotic cells, very specific, is that to hit how would we say that? Kunsen hypothesis? No, I don't. Let me see. I don't think does it happen in this case. So let's see what you're saying here. Are you talking about the wobble phenomenon? Or let me see.
Looking for tumor suppressor gene when they lose the function. It's something.
Yes. I got it. Definitely. Yes. So VHL is suppressing. Let's be very clear. Yes. This is a tumor suppressor type of gene that would manifest itself on chromosome 3. So yes, it's a 2-hit type of problem. So what do I mean? Well, this is what I mean. If, for example, I have the property of VHL, let's say, which is basically blocking HIF, like we mentioned, right? It's not allowing HIF to function. Let's say I have 2 VHL, because we're going to have the expression of both of them. They're both going to be expressed, right? If I lose the expression of 1, I'm still okay because this is a tumor suppressor. It's stopping the liberation of HIF. So yes, in order for this to occur, you have to have a very serious problem here in this sense where you'll notice that it's a 2-hit problem, right? The first hit usually is like hereditary cases, right? Second hit can happen many times when you have some kind of mutation. But yeah, so the name was slipping me, the Knudsen hypothesis. But yeah, there's that, I would call it more than a hypothesis. It's actually the expression of a tumor suppressor gene. If it loses its expression, albeit for some kind of genetic problem or some kind of acquired mutation, what would happen is that as long as there is the other gene being expressed there, you'll be able to still inhibit HIF. But if you lose both, if both of them are lost, well, then HIF is now liberated. HIF increases, hypoxia transcription increases. So that's different than oncogenes. Oncogenes, all you need is 1 hit. All you need is 1 hit because oncogenes are proactive. Oncogenes are stimulating the proliferation. They're active mutations. All you need is 1 proto-oncogene to have a mutation. Then it's going to be proactively causing problems. That makes sense. It makes sense, right? Does anybody understand that? Right? If you don't understand, let me know. If you don't understand, let me know. I can explain it in other ways. All right, but that makes sense. Okay, so what I'm saying is HIF is liberated. It's free. Free. Okay. So HIF starts to enhance the promoter region, which will then have affinity for transcription factors. Transcription factors will bind, and then that itself allows for RNA polymerase to bind. Now, let's be very clear. RNA polymerase, the one that makes mRNA, is called RNA polymerase type 2. Type 2 makes mRNA. Remember that? Prokaryotic cells only have one RNA polymerase. Eukaryotic cells, our cells, we have three different, there might be even more, but let's say three different main RNA polymerases that we use. So the one that codes for mRNA is going to be RNA polymerase type 2. Okay, so that mRNA will come out. That mRNA will then basically, well, let me not even draw EPO. Let me just tell you that mRNA will get created, right? It gets created, but it has to leave the nucleus. In order to leave the nucleus, there's 3 steps we should remember. Child Protective Services. Keep that in your mind. CPS. CPS. That's what they call it out here in New York, in the United States. Whenever something is wrong or, oh, this kid is getting abused or something, they say Child Protective Service. So the mRNA is like a baby. It has to be taken care of. Yes. Child Protective Services. So child is for capping. You have to have a process of capping this mRNA. Then you have a poly A tail, which gets added. A very strong A, poly A tail, right? And then you have spliceosomes. Spliceosomes. Definitely. Spliceosomes, you have introns and extrons. Introns, basically, the introns will stay inside, and then extrons are able to assemble and then leave. So let's remember one concept that we have on biochem, that mRNA with prokaryotic cells tend to be polycistronic, while mRNA on eukaryotic cells are monocistronic. So what do I mean by that? A eukaryotic cell, well, let's just say human cells. Let's simplify it. Our mRNA specifically codes for one protein. So mRNA is going to translate, when it translates itself, it has to go from being a sequence of nucleotides like thymidine, adenosine. It has to go from being a sequence of nucleotides to then becoming a sequence of amino acids, right? A long chain of amino acids. It has to translate. So, like I said, capping poly A tail, let me put it right here, poly A tail, and spliceosomes. Splicing, which is done by spliceosomes. And after that, then you have your mRNA finally, because before you have your premature, your heterochromatic mRNA, but now you have your solidified, solid mRNA. So mRNA has to translate its information from nucleotides into proteins. And how does it do this? Now this is different. This is not transcription anymore. Now we call this translation. Translation, guys. Translation is when mRNA meets up with the ribosomal subunits that are found in the cytoplasm. So how does this happen? How does this start? I'll just tell you the beginning. We won't go through everything because I bet if we do, it's too much information. But let's just put it like this. mRNA, it has a very specific area to it. In the eukaryotic cells, we call this Kozak sequence. This is able to find the 5S portion of the 40S. And this here has a complementary type of expression. So mRNA is now able to specifically find the 40S, right? And bind to it. Boom, it binds. So just to let you guys know, it binds. What happens next? Well, next, you'll end up seeing that this here is going to have APE. Now, I have to be very clear with everybody. Every step here is regulated because there's things that do not allow the next step to manifest itself until the main step is complete. So it is very much regulated step by step. So when you have this expression here, APE, you're seeing, the P will express the start codon, AUG, and AUG will code for methionine. It's coding for a methionine. So we have tRNA out in the cytoplasm doing the good work for us. tRNA is picking up. So let's look at a tRNA. Let's understand the structure pretty well, just in case you get tested. Just in case we don't understand the structure of it. So let me look at it like this. Down here, you have anticodon, which will have the complementary expression to whatever it needs to bind. Here you're seeing this is the start codon. So it has complementary nucleotides that will have affinity for that. So we would say, let's see, UUC, it looks like. Well, I would say UAC. That would have to be the complementary of that. So that would bind to it. Okay. So then, of course, that's what we have here, the anticodon region. Then here we have the T arm. The T arm is very important because it can find the ribosome using the T arm, the T tethers. Then here you have the D arm. The D arm recognizes a very important type of enzyme. This enzyme is called amino acyl tRNA synthase. I think I'm adding a extra syllable there. Synthase. Okay, this enzyme is recognized by this arm. So what does this enzyme actually do? Well, when you pick up the actual amino acid, and this region here would have a very specific portion that allows it to pick up amino acids. You're not just supposed to pick up amino acids with any kind of protein, but this here has an arm that says CAA. It's CCA. Can carry amino acids. That's a special arm that it has. But okay, it carries the amino acid methionine. But then this enzyme here is responsible for the phosphorylation of methionine. And you have to use an ATP for this. You have to use an ATP, creating a pyrophosphate afterwards. But yes, this is a very important process. This is called charging. You are charging your tRNA in order for it to then be able to bind the 40S. Okay? In order for it to be able to bind the 40S. And when that is able to actually enter this area, every step is regulated by something called factors. This is the process of initiation. There's 3 processes here that go on with translation. You have initiation, elongation, and termination. Since this is initiation, we have factors that control every step. So after this binds, then you'll have GTP is going to react with the initiation factor. That allows it now to have the next step. You're going to see that the 60S will then join the party. The 60S will now be able to join and it will assemble. Once this assembles, that's when now you have finished your initiation process and you're ready to go for elongation. Because now you will express a code here on the A site, on the arriving site, for the next tRNA. So this here is called initiation. That's the process of initiation, when all the pieces assemble together. Okay? And when all these pieces finally assemble together, and then more tRNA comes in, and it basically builds up a very long chain through the process of elongation. Once it recognizes a stop codon, you are away, you go away, right? UAA, UGA, right? Once it finds one of these stop codons, it's now able to have releasing factor. It then releases itself. Once it releases itself, now you have an EPO. Now you have successfully turned your mRNA into an EPO. All because you had hypoxia. This whole story just started with somebody who had hypoxia. Now, EPO is able to travel and bind to its own receptors. Believe it or not, you have receptors for EPO. The receptors are actually found on premature erythroid cells, so RBCs. Let's say premature RBCs. They actually have receptors on them that allow them to basically have a ligand receptor reaction with EPO. This promotes the differentiation of RBCs. This promotes RBC growth, more stimulus, So your hematocrit can increase. So your red blood cell mass increases. So now the patient will have higher level of hematocrit. Remember, the blood itself, the blood, is made up of different type of components. It does have some component that's just basically RBC. We call that hematocrit. Hematocrit. Now, if we strip the blood from all the cells, white blood cells, red blood cells, we leave the platelets, we leave all the volume, all the fluid. What ends up happening is you then end up having plasma. Yes. Good, good, good. All right. So, uh, yeah, definitely, definitely. So let's look at EPO. What specifically about EPO? EPO, its mechanism, how it works. EPO, it has its affinity towards RBC. Oh, okay.
Yeah.
The part after the translation. Okay, after you have translated successfully in EPO, EPO itself will have affinity for precursors of RBC, erythroid progenitor cells. They would want to bind these cells in order to amplify the differentiation and also to promote more proliferation of RBC. The myeloid lineage will get stimulated. And EPO is doing this, remember, through the second messenger system. I want somebody to tell me what second messenger system does EPO use? Does anybody remember? Anybody know? JAK-STAT. Good. Awesome. Awesome. That's awesome. Yes, JAK-STAT. It does use JAK-STAT. So here we're seeing that more EPO will actually go and stimulate the precursors of RBCs. The erythroid progenitor type of cells will get stimulated. They have an actual receptor for EPO. So once you start doing that, you start to have proliferation, differentiation. So you start to have more RBC. It's just that simple. EPO increases your RBC, and it comes from the kidneys, from the parenchyma cells of the kidneys. Kidneys are very sensitive in sensing hypoxia, also in sensing the blood flow. The blood flow. It has a very high demand. It wants 20% of your cardiac output, and it doesn't really like to negotiate. It starts to manipulate the system if you start giving it less than 20%. So cardiac output, let's say, is 5 liters. It makes sense that the kidney is demanding 1 liter. 1 liter. Right? And not only that, if the kidney is demanding 1 liter, if we are to strip down this blood, let's say, and eliminate the hematocrit and just leave it to plasma, and we want to calculate the renal plasma flow, let's say, typically, I'm just giving you an estimate. Normally, the renal plasma flow should be about 60% of the renal blood flow. So if you're seeing that it's 1 liter, it should be about 600 milliliters in that sense. RPF, roughly. So just letting you know, this is a close relationship that you will find when it comes to all this. But of course, there's situations, scenarios where you would have to calculate how do you get the renal blood flow by just having renal plasma flow. So let's look at one equation here. Let's do one of these equations to try to find out exactly how you do this. This is just a little review I'm giving. Then we're going to do more questions after this. Just reviewing a little, then a little more questions. So renal plasma flow. They're asking me to work backwards because here, let's say I had blood. And then from blood came the plasma. So I'll say this much of the blood was plasma, let's say. And now instead, I'm doing algebra here because what I have is this. I have the plasma, and what I want is the renal blood flow. So how can we calculate this? All right, first thing that we do is that we try to strip the blood and make it look as similar as we can to the plasma. So how do we do that? So you'll notice that in the formula, what you end up doing is that you are to subtract 1, which is the whole number. This is representing 1, right? This is 1 unit of blood made up of all its elements. But here you want to specifically subtract the hematocrit. Take away the hematocrit because that is not serving our purpose. That's just red blood cell mass. So here we're going to subtract that. That's how you make the blood look very similar to plasma before we start solving equations. So when you do this, you'll get a specific type of number. So I will, let me put in an equation here and we'll solve it real quick. So first off, formula. So the formula for this kind of equation is going to be like this. You're trying to solve for renal blood flow. In order to solve for that, you have to do renal plasma flow divided by 1 minus hematocrit. Basically, 1 minus hematocrit. So let's look at a question. Let's try to get that. Remember, the bottom here, you're just trying to get your blood to look a lot like the renal plasma. And then you do this division. That's all you're doing in this equation. So let's take a look at it. A researcher estimates that a patient's renal plasma flow is 600 based on PAH clearance. Yeah, let me just tell you, PAH is going to allow us to know, to estimate more or less the renal plasma flow. It allows us to estimate it, but it gives us the answer like in some kind of flow. So, okay, 600 ml per minute based on PAH clearance. If this patient's hematocrit is 45%, what is the patient's renal blood flow? So first things first, hematocrit. So I instead of trying to memorize formulas here, I'm just thinking to myself, I have the product. I have the plasma. What do I want to solve for? The ancestor, let's say the origin, the original structure, which is the blood. I want to find out what is up with the blood. So what do? I strip the blood from its foreign properties and make it look more and more like plasma. How do I do that? I subtract it by the hematocrit. So the blood counts as 1. So I would do 1 minus 45. That should give me 55. And they said 600 ml is the RPF based on PAH clearance. So I have to say 600 over 55. And what will that give me? I don't know. Let's see. Calculator. Oh, I did this question before today. Okay. Yeah, we got this. The calculator says if we solve for this, 1091. Boom. So the answer might not show up, so you have to round it up. Round it up. Seen this in an MBME question where you have to end up rounding. The question was not exact. It was off by a couple numbers. The answer, so you do have to round. The answer there is D. Okay. Good. Any questions? If not, we continue. We're going to do questions now. We are going to do questions. So raise your hand if you want to go first. I'm going to post a question. We'll analyze it. We'll read it. We'll talk any type of strategy that we have to take in order to answer it correctly. We'll see exactly how tricky it can be. You're free to participate. I hate those questions. Which ones, Carrie? Oh, nice. Carrie has raised her hand. Carrie, yeah. Okay. Yes. Yeah, remember we gave a whole class on that, Carrie. That class, yeah, it's always important to go back to that class and look at all those crazy equations with clearance and excretion rate and all that. Definitely, because those calculations, they are kind of annoying. Let's be real. They are kind of annoying. Why? Because I don't see them like intervening with other subjects. It's like you have to study that specifically. You're not going to bump into it in any other realm of medicine. I like things that get associated. Comes easy to me. So, okay, let me just post this question and you'll answer. And here's the good news, Carrie. You were brave. You raised your hand. You didn't even think about it twice. You said, I'm good. It's not even a question based on equations. Yeah, this is a question that's just based on renal physiology. So we'll take a look at that right now. Let me see. I'm trying to find it. Put it. I'll find it. Hold on. I set a couple of them up. So that was a brave move right there. And let's see, this one is. Um, there you go. All right. Let's give you this one. Let's see.
Okay, let's see. Which of the following most likely accounts for the higher creatinine levels seen in patient B? A lab technician processed basic metabolic panels for two patients. Patient A is an 18-year-old and patient B is an 83 years old. Neither patient takes any medications regularly, serum lab studies show. So patient A's sodium is fine, potassium is fine, chloride, I'm not sure if it's a little bit high. I can remember the range. BUN, it's okay. Creatinine, patient B is a little bit high. And glucose is fine. Also, it is, okay, so it's normal.
Yep, normal.
And potassium is normal. Everything is normal. Which of the following most likely accounts for the higher creatinine levels in patient B? Okay, so patient B is the 83-year-old, right? I'll say normal aging.
Normal aging.
That's what I think.
Okay. So
Because low bone density, mineral density, I don't think so. Insulin resistance, his glucose level is okay. It's still within normal range. Volume depletion, nothing here tells me that there's a volume depletion. You know, sodium is fine. And renal function, you know, it's, even though it's still a little bit high, but that could be high salt diet. Iffy. Low body mass index. I'm not sure about the low, but so I'm thinking it's normal aging. That's
okay,
the
yeah.
problem with normal aging.
Yeah, you would be right, definitely. As we get older, you'll notice that the GFR starts to decline. And it's part of it's just it is normal. We do have certain types of ranges of GFR in order to measure for chronic kidney disease. And at this sense, this is not considered any kind of pathological issue. It's completely normal, and they did try to throw you off a lot with the idea of body mass index, because the creatinine is very much relative to how much muscle mass the patient will have. So a patient with more muscle mass will have release of a higher level of creatinine,
Okay.
especially if you're doing exercise and things like that. So that right there, they try to kind of throw you off with that. But yeah, you stuck to your uh, main idea, and that is true. Age related, you'll start to see this as a problem with older patients in that sense. So yeah, older patients tend to have a lot of different issues. Um, Something else that we should actually mention. I know I mentioned this today, so let's reinforce the fact. I was talking about AA gradient. So there is a way of calculating AA gradient for older patients. Just because when they get older, the values do change. Yeah, the lung starts to change as the patient gets older. A lot of physiology will change. A lot of physiology. So here's the equation that we use in order to calculate an AA gradient on an older patient. So what is the AA gradient, first of all? Remember that we have the idea of getting, let's say, you put it like this. oxygen from the atmosphere, which is FiO2, oxygen from the atmosphere inside our ventilation system, right? In order to get it into the lungs, it has to go through our ventilation system until it reaches the alveolar, the network of alveoli. All that oxygen has to go here. That's called ventilation. So after ventilation, you'll notice that there is perfusion. This oxygen then has to go into the vessels. And capital A represents the partial pressure of oxygen in the ventilatory system. The PaO2 lowercase represents the dissolved partial pressure of oxygen in the blood. So the act of getting this from the alveolar into the bloodstream, this idea of getting that in there, that's called gas exchange. That's called perfusion. Perfusion. The idea of getting oxygen from the atmosphere on into the alveolar system, that's called ventilation. So you have to measure the amount of oxygen that got in through the ventilation system, and you subtract that by the amount of oxygen that's in the blood. It should give you a number. In normal patients who are not 85 years old, normal patients, 5 to 15. Right? We don't even need to calculate for age in that sense. But if it's an elderly patient, you need to calculate for age. So how do we calculate for age? The equation looks like this. You have basically age. So let's look at this patient actually. How old was he? 18-year-old versus 83. So you would have to, let's say he's 83. So 83 years old, which is age. Just write it here just in case. And this here will actually be divided by 4. And then your answer here would have to get added by 4. And that right there would show you the range of AA gradient. The range of AA gradient. So that's how you would calculate. That's how you solve for AA gradient. Okay? That's how you would know. All right. Good answer. Thank you, Carrie. Miriam, saw you before, Miriam. If you want to take the next one, let me know. All right.
Oh, yeah, I'll try. I know. I'll try.
All right. Perfect. Good.
I'll give it a shot.
That's good. Got to take advantage. When I see bravery, I take advantage. Definitely.
Oh, no.
Definitely. Let's see. Let's look at this question right here.
Okay. Okay, let's do it. Okay, after her previous appointment, this patient was most likely started on a drug that has which of the following effects? Okay. A 48-year-old woman comes to the physician for a follow-up examination. At her visit 1 month ago, her GFR was 100 ml per minute, 1.73 m square, and her renal plasma flow was 588 milliliters per minute. Okay. Today, okay, her renal plasma flow is 540 ml per minute. Okay, and her filtration fraction is 0.2. Okay. So, let's see what's going on. Okay.
So yeah, this is kind of like that algebra thing where they gave you the filtration.
That's right.
Remember this equation right here. Filtration fraction is equal to GFR over renal plasma flow. So what we're seeing is that a month ago, so let's organize this a little. A month ago, the patient had a GFR of 100 per minute, right? And all this other per minute squared. But she had, if you look at this, you'll notice that her renal plasma flow was 588. So that was before. Today, all they gave you was the filtration fraction. So the filtration fraction is 0.2. And then they said that her renal plasma flow is 540. So GFR, we have no clue, right? So it's like a X. And 540 for renal plasma flow. But whatever it is, it's equal to 0.2. So
if we calculate the first one, if we calculate the GFR for the first one, right?
First off, before even going in there, one thing
Ah.
that I love to do with these type of questions, one thing that I love to do is I reread that stem after looking at all those numbers. I reread it because it might just be that you don't really need to calculate anything. Let's see. Maybe you have to. Let's see. It says here, after her previous appointment, this patient was most likely started on a drug that has which of the following effects? Oh, okay. So she was started on a drug that has what effect? They want you to draw a conclusion based on the numbers that you're getting. So yeah, I would have to say, let's see.
Yeah. Okay. So I would you gave me the answer. So you just told me that GFR, you just gave us the very important equation. So I would calculate the filtration fraction for her first month, right? Her first visit. And that would be 0.17. So what happened is that today her filtration fraction is 0.2. So now after taking the drug, her filtration fraction has went up. Right?
Okay, so hold on. So let's so you just said that a month ago it was 100 divided by 588. Got the calculator open. Let's see.
That was 0.17.
Correct. So 0.17. And now this time around, we're seeing that the filtration fraction
is 0.2. So she's got something going on that is improving her GFR, which of course that would be most likely an ACE inhibitor that is causing constriction of the efferent arteriole. So because that's the only thing that would increase the GFR.
All right, that's really good. So what's the answer here?
That would be E.
That is correct. Great answer. Great answer. And that's a perfect way of getting it. So let's connect that. I'll show you like the instant replay, like in sports, when you do a home run, they show you a little instant replay. So I'm going to tell you exactly where you were able to apply the concept that you need to know. So you were able to apply this. I'll tell you where. Once the calculation was done, right? Once you found that before it was 0.17, now it's 0.2. You drew a conclusion here. You said that the filtration fraction has increased since her last visit a month ago. So since you said that, we would then say, what can increase the filtration fraction? And I mentioned this before. There's going to be this one thing, this one concept that we need to understand. Understand this, not even math. It's kind of like logic. It's the idea that the numerator and the denominator, let's say. So here, for example, we're doing GFR, and then denominator, plasma flow. And we're saying that this equals filtration fraction. So let me be very clear. If I increase the numerator, I will increase the filtration fraction, the number on top. If I increase the number on top, then the whole number should increase. The whole number here is represented as the filtration fraction. So we don't even need to solve too much. We can just look at it and say, I can manipulate the filtration fraction. I can make it increase if I increase the numerator. Or I could also get an increase if I decrease the denominator. If the denominator decreases, but the GFR stays normal, then I should have an increase of filtration fraction. So Dr. Carey says, is that the same with pH and bicarb and CO2? What do you mean? I have to draw a conclusion on that. What do you mean with pH, bicarb, and CO2?
Well, basically, because the pH, right, is the whole number, then pH, you know, when you do the is it not the fake? What is the that equation called for the pH?
There's two different ones. There's the one called Winter's equation.
No, not the one. The other one.
The other.
Oh my God! So it's that? No, it starts with an H, something like that.
I think you're
That's
talking
all
about the
that.
Hendelson-Hasselbalch equation.
Mhm.
That one
That
is a
one.
bit. That one is a bit different. That has to do with the idea of when it comes to the dissociation of drugs, for example.
No, it's not that one. It's the one that is pH equals HCO3 over CO2.
HCO3,
yeah, bicarb over CO2.
CO2.
So basically, if the HCO3 goes up, then the pH is gonna go up. If the CO2 goes down, the pH is gonna go down.
Okay, yeah, I see what you're saying. Yeah. If you have, okay, so yeah, if you, I wouldn't quantify that with numbers, for example, because that's where it gets a bit hard. Why? Because one molecule of CO2 is very sensitive, like it's equal to a specific type of number when it comes to pH. Yeah, we see that in the Winter formula. Like there's a specific type of let's say it's something that could be quantified. But if we want to just approach this with concept, this makes sense in that realm. If we're just talking about something alkaline increases, then yes, that will affect the pH. If something that's acidic decreases, but the alkaline stays normal, then yes, the pH will increase. You see, that's the same idea there with that concept as well. Another concept I can tell you, pressure. I remember we talked about this in the left ventricles. We mentioned one thing that was very important. We said volume and space inside the left ventricle. If we basically have decreased amount of space in the left ventricle, then the pressure, the tension in the walls can build up very fast, very easily. And then we also mentioned if we have more blood, more volume inside that ventricle, well, the volume itself will definitely cause a stretching, which will then increase the pressure overall. So it's the same. There's a lot of different types of scenarios like this. So try to use that to your advantage whenever you see that idea. And this is what was connected perfectly here, because once we established that filtration fraction 0.17 was last month, and then this month is 0.2, we could naturally think there's two things here that could have contributed to this. One can be a decrease in renal plasma flow. Right? If you decrease your renal plasma flow, you'll have an increase in filtration fraction. The other could have been an increase in GFR. So yes, they couldn't put both of them in the answer choices. They couldn't. They just couldn't, because then you wouldn't be able to have one answer. So yes, constriction of the.
Can you just repeat the last one, just the very last?
Sure. So there's two ways you could increase your filtration fraction here. There's two ways that we can increase it. If I decrease my renal plasma flow, then you'll see that if the GFR is able to maintain itself normal, then the decrease in denominator will give you an increase in filtration fraction. Does that make sense?
Isn't that would be constricting the afferent arteriole?
If you constrict the afferent arteriole, for example, you will not have enough renal plasma flow. Right? That would decrease. Dilating the efferent. If you dilate the efferent, You would have less GFR though. That's the thing. RBF is constricting. Well, here we're already calculating for RPF. You're seeing that if you constrict automatically, you have decrease in renal blood flow. Remember that. If we are constricting, we are not allowing perfusion to occur properly, right? Whenever you have a potent constriction, you are now lacking perfusion. ACE inhibitors dilate efferent arteries. Yes, they do. So ACE inhibitors. So hold on. You're saying constrict or dilate? Okay, good. Because why? Because angiotensin 2. So let's be very clear. Let's say this is afferent and let's say this is efferent. Angiotensin 2 constricts the efferent more than it constricts the afferent. So it has more efferent constriction, angiotensin 2. We understand that. ACE inhibitor will eliminate angiotensin 2. You won't be able to make it. So therefore, instead of constriction of the efferent, you'll have more dilation. So ACE inhibitor will dilate the efferent arteries. Yeah, you are right there. Does that make sense?
Now let's see what's the drug again, because I'm confused.
So did they mention a drug? They said the mechanism here
After the
is
previous one, the patient was most likely started on a drug that has which of the following effect?
so what drug do you think it is?
So, okay, so now we know that the filtration fraction is getting better, so the GFR is getting better. So we said that this has to be constriction of the afferent arteriole, right? Of the efferent, constriction of the efferent arteriole, right?
Constriction of the efferent, yes. Constriction
Yes,
of the efferent.
we were able to conclude that, yes, and that would increase the GFR. But I still think if we reduce the renal blood flow, won't the filtration fraction be high as well?
Say that again. If you
Drop the renal plasma flow, won't the filtration fraction be high?
if you drop the renal plasma flow, will
Just
the
from the equation, like, because they're on negative sides, right? If you draw the dominator, the filtration fraction would be higher.
well, this is the problem though. If I decrease, like let's say you end up decreasing the renal plasma flow, let's say, wouldn't that also decrease the glomerular filtration?
Glomerular filtration rate.
Or do you see what I'm trying to say? Like, for example, if this goes the same direction, for example, if I have a decrease in RPF, but I also have a decrease in GFR, filtration fraction should stay the same. You see what I'm trying to say? It'll just stay the same. Because if I am not having, okay, hold on. So Ngozi says, yes, I'm confused now then. Won't be RPF increased. So in this situation here with this patient, let's say this scenario. So I think we're talking about different scenarios. I think that's why people will get confused. So let's talk scenario by scenario. So first, let's address the example you're giving. You're giving what example exactly? Let's see. What example are you talking about? You're talking about a scenario where you have less renal blood flow. I think that's what you said.
Yes, I was saying, so what we have in this case is that the patient, after taking the drug, the filtration fraction has increased. So I'm thinking there's two ways to do that. Increasing glomerular filtration rate or dropping the renal plasma flow, right?
Yes, correct.
So they give both, right? They give D and E. So they gave, like, D is constriction of the afferent artery. Won't that drop the renal plasma flow?
Constriction of the
Afferent artery, won't that drop the renal blood flow and the renal plasma flow?
That should stop the renal blood flow, yes. But here, this is the efferent. If it's the efferent that's constricting, it will increase the glomerular filtration rate. It'll increase the glomerular filtration rate. Why? Because it has to
afferent.
produce.
I'm talking about the A for afferent.
Oh, now you're
Won't
saying.
the afferent,
Oh,
if
okay, so
it's
hold on.
constricted, it will drop the renal plasma flow and then increase the filtration fraction?
Okay, so
Based
you.
on the equation, just based looking at the equation, if you drop the denominator, won't your end result would be higher?
I'm going to tell you what the problem is. If yes, based on the denominator, what you're saying is correct, but it depends how you drop it. You see, you said something about afferent. You said afferent.
Yes.
Yeah, what you're saying is true, except not for afferent, because in afferent, remember the afferent is bringing in the blood into the system here. So if you decrease renal
Oh.
plasma flow in the afferent,
Both will drop.
Both
You're
will
saying
drop.
so both will drop, and then your filtration fraction won't. Nothing will happen to the. Okay, I get it. So
yes,
if,
because just
okay,
because
so,
it's the one that comes before.
Yes. So D, if okay, simple English constriction of the afferent will drop both GFR and the renal plasma flow, and your filtration fraction will be normal. So this is not even an answer, all right?
Yeah,
This is normal.
perfect.
And
Filtration
yes,
fraction would just be normal. Why? Because
that's right.
you the blood that you're bringing to the game, to the field, the blood that you're bringing is now
Yes,
limited.
that's
So
right.
guess what would also be limited? The filtration fraction, the
Yes.
GFR.
Yes.
You
So we're
see?
back to where we were thinking from the beginning. Constriction. Now, what drug is that? That's the
Yes.
question.
Yes. So now
So what is
let's
going to cause constriction of the efferent?
oh, nice Mona. Mona shared a nice picture here. Hey Mona, I didn't even see you in the class. I now see you. How's it going? Let's see. Mona always has really nice files to share. She showed this file right here, and it makes a lot of sense. This is the file here that's just showing you the relationship between all this. I do not want to get confused though. Right now we're flowing nicely. We're finding out the drug. The drug that they're talking about specifically has constriction of the efferent arteriole. Constriction of the efferent arteriole. So what kind of has which of the following effects? So so Ngazi, hold on. Ngazi, you were talking about this. This is what you were talking about before. So can you tell me more or less what drug do you think it is? Because here we're able to think. If you have constriction of the efferent, we can say right away it's not ACE inhibitor. It can't be ACE inhibitor, right? Because the ACE inhibitor is taking away a potent type of constriction. Sacubitril, that seems like a very good option. That seems like a very good option, but this is the problem. Well, sacubitril does cause dilation of the afferent and constriction of the efferent, right? And it doesn't do it itself, of course. It's inhibiting niprosilin, and niprosilin is this proteolytic type of system that breaks down your AMP and BMP. So AMP and BMP, when they're high, they tend to dilate the afferent and constrict the efferent.
Oh, well, you just said the answer.
So yes, it's looking, yeah, it's looking like that can be the case in that situation, definitely. So yeah, it definitely something that will
On that line, that's right.
yeah, that would basically cause this kind of that was a really good question. I like the way.
Can I say something?
Yeah, go ahead.
Wouldn't it be easier just to look at the renal plasma flow that says in one, renal plasma flow was 588 and then decreases to 540, and then you know that if the renal plasma flow decreases because you're constricting the efferent, instead of going through all the formula and all that.
Yeah, definitely. You could have definitely gone that route. Yes, definitely. But I'll tell you what happens. Carrie. That is the best route to go, actually. You can just look at it like that and try to get the answer but I'll tell you what happens. Potentially, I'll tell you why that can be a little bit tricky if they really want to be evil. Because remember, this can have two different types of situations. You can have the decrease of RPF, let's say, and the increase of GFR.
Got
Yeah.
it. You still have to take in consideration the GFR in order to find out the filtration rate.
Yeah,
The filtration fraction, I'm sorry.
because they could kind of mess with you in the sense where they can say, okay, well, it has an increase in GFR, or they can say something where they're saying a decrease in RPF. But then that kind of makes me think, hold on, decrease in RPF also decreases the GFR. So
sorry for interrupting. Constriction of the afferent arteriole is going to decrease the RPF too.
yeah, definitely.
So we cannot go in that way because here
it'll-
the GFR is making the change actually.
It'll decrease
Deciding
both.
which one is that.
Yeah, so it's like it's in the situation where you have constriction of the afferent, you're going to limit your RPF. But the thing is, you also limit your GFR. You see what I'm trying to say?
Yes.
So that's the problem. So filtration fraction should look more or less normal in that sense. Yes. But yeah, that was a good question. That was a good one. Definitely, we could have just got it with the straight up looking at the renal plasma flow and then plugging it all in, right? That would have been nice, but it's all good. Let's look at an AMBOSS question. Let's see what we got. Who wants to do the next one? Just raise your hand and we can get the next one. Let's see. Let's see. Hold on. Let me get a good one. I saw a couple of NBME questions as well. NBME, I don't like those questions that are just pure trickery. I like questions like we just did right now. Questions that will mess with the physiology, not mess with semantics or things like that. All right, let's see. Let's check this out. Let's go with AMNA. Haven't seen AMNA tonight. Let's see what AMNA. Let's see what you got here. Let's go.
Okay. So, which of the following is most likely the mechanism of action of this hormone? Okay. So, an investigator is studying the patients with acute decompensated congestive heart failure. He takes measurements of the hormone released from atrial myocytes as well as serial measurements of left atrial and left ventricular pressures. The investigator observes a positive correlation between the left atrial pressures and the serum level of this hormone. Okay. So they're asking for the mechanism of action, and it's a hormone that's basically released upon decompensated congestive heart failure. Okay. So I'm thinking that it might be the ANP and the BNP.
Yeah, right. It makes sense. It does make sense, especially when they're talking about the atrial and the ventricular type of pressure. It makes sense.
Okay, so they're asking about the mechanism of action. Okay.
Yes.
So decreases the sodium reabsorption at the collecting tubule. Okay. No, I don't think so. Increases the potassium excretion at the collecting duct. No. This seems like an action of like aldosterone agonist kind of action. Okay.
Increases potassium excretion, yeah, like a mineral cortical.
And then constricts the afferent renal arteriole. Okay. No, I don't think so because it dilates the afferent and constricts the efferent in order to bring about the increased excretion of the fluid. And then decreases the reabsorption of bicarbs in the proximal convoluted tubules. Okay. Okay, this seems like RTA type 2.
Yeah,
Yeah,
definitely.
yeah.
Oh,
And then
well,
I like
yeah.
this one.
That's that drug. What's the drug name? Can you tell me the drug name for D?
Yeah, acetazolamide.
Acetosolamide, correct. This is acetosolamide.
Yeah. Okay. And then we have the increase in the free water reabsorption from the distal tubules. Yeah, I don't think it's D. And the reabsorption of water from the distal tubules will be increased when it's if there is like a issue with the osmolality of the serum.
Right. So what does this? Do you know exactly what can do this?
Yeah, ADH.
ADH, right? ADH can activate the
Yeah.
aquaporin channels in the principal cells. The principal cells. Yes, good.
Yeah. So the only one that's left is the A, the one where we have decreased sodium reabsorption of the collecting tubules. It does make sense as well.
Okay. So
Yeah, so I'm gonna go with A.
A, your final answer. Yes, you are
Yeah.
correct. Good for you. You got it. That's perfect. That's good. You went in there, you did a process of elimination, you made sure you get the answer right. Now, so
Yeah.
let's yeah, that's a good one there. Definitely. You'll see that this is one of those peptide types of hormones that are kind of tricky because it has many different mechanisms. I remember calcitriol. Um, I remember no, it was calcitonin that has a couple of mechanisms that all contribute to the same action. Here, the action that we are trying to achieve is to minimize the extra volume that the patient has. You're trying to decrease your preload. You're trying to minimize the excessive amount of preload that you're having in the body. So any answer that tells you an increase of volume is definitely going to be the wrong answer. Remember, this is like an emergency system where the atrium was stretching. That stretch allowed the release of AMP. And then
I'm
AMP is,
promoting the diuresis here, right?
yeah, you're basically promoting more diuresis in order to get rid of volume in your body.
Yeah.
These patients have pitting edema. So any answer like E made no sense, for example.
Yeah.
Increasing the potassium excretion, that's kind of what aldosterone does. And remember,
Yeah.
we did mention one thing, the ENaC channel. So yeah, let me show you that principal cell that I had here before. The ENaC channel, very important. Let me put this here on the screen. Well, let me take away that potassium area here, not to confuse anybody. There we go. Okay. So this is going to be the principal cell. And we do have, so when aldosterone comes into this principal cell, it's going to upregulate the transcription. It's going to promote more expression of sodium potassium ATPase, more expression of ENaC, and more expression of ROMK. So that way you'll be making more of these channels. So, okay, that makes sense. That's awesome. ENaC, remember, is in charge of allowing you to reabsorb your sodium from the urine onto the principal cell. And then from the principal cell, you'll have your, yeah, this is backwards here. This potassium should be coming inward and the sodium is going to the blood. So sodium goes back into the bloodstream. Remember, sodium is one of those famous osmoles. We have 3 different famous osmoles. I'll keep on repeating it. You can get it into your head. There's going to be sodium. There's going to be glucose and protein products. So protein, what do I mean? I mean urea, I mean ammonia, right? All this type of protein, amino acids as well. They're going to have, this is everything that has osmolality. And it's so important that we know this because when we're doing the equation for osmolarity, it's based on, so yeah, let me show you the equation for osmolarity. And it shouldn't be a shocker to anyone. Let's see. Osmolarity. osmolarity equation. Yeah, you don't need to memorize this equation at all. You don't even need to use it. But what is important about this equation is that you're able to use this just by knowing the elements that we're dividing and moving around. You're able to get. So basically, we have this. Yeah, definitely. Yeah, that's perfect, Dr. Gary. Let me use that. Let me just copy and paste that. Yeah, basically, what we're seeing is 2x sodium. Notice sodium because it's plays a primary role there with osmolarity. Glucose divided by 28. Glucose again. Yeah, I did not memorize that at all. I did not memorize that at all because I feel like you never really have to calculate it. Glucose. Okay, yeah, glucose. And then the last one was, of course, BUN. BUN over 2.8. Okay, you see it there. You see what I'm trying to tell you. The players of the game, sodium, glucose, and BUN. Okay, so let's take a look at this. ROMK is responsible for the excretion of potassium onto the urine. And then, of course, your sodium, potassium, this here is going to allow for this to flow in and out of the blood. Okay, so what is the big deal here? I'm going to include now 2 hormones, 2 of them. ADH. ADH is able to activate here aquaporin channels. These aquaporin channels are going to facilitate the entry of H2O into the bloodstream. Oh yeah, definitely. Yeah. Yeah, you're right. So this here is allowing H2O back into the bloodstream. And remember, ADH is activated by the difference in osmolarity. You can sense when you're you have a lot of solutes, right? And it's going to be released from the posterior pituitary. So that is ADH. But okay, we also have something else we're seeing now. We're also seeing some extra stuff here. So let's do this association real quick so everybody can understand. What are we also seeing? We have also just saw right now that AMP, BMP has the ability to inhibit this ENaC channel. Inhibits the ENaC channel. So it's counteracting the action of aldosterone. It's counteracting the actual action of aldosterone, not allowing ENaC to work. And let me explain something to you that's very specific here. ROMK and ENaC are working in tandem. They are allowing their system to function just because of electronegativity. The electronegativity is really important here. They have to both be working in order for this to flow properly. So if you inhibit your ENaC, ROMK will not work. If you inhibit the ENaC, ROMK will not work. This, although it might look independent, they are flowing together through electronegativity. So that's what you see here. Now I'm going to add something else to this, a weird side effect. TMP, guys. Let's remember TMP. TMP can inhibit ENaC. And when it does, it causes hyperkalemia. So yes, in the text, you'll see it'll mention that TMP, this drug, trimethoprim, the drug that's responsible for inhibiting dihydrofolate reductase in prokaryotic cells, you'll see that they'll say that it causes hyperkalemia. Well, this is the mechanism of how it's inhibiting ENaC, therefore inhibiting ROMK. So you cannot excrete your potassium. Therefore, you're holding on to more potassium. Therefore, you're having peaked T waves. Right? Good. We understand that. But we have to, what else? There was something else I wanted to include as well. Remember that ADH as well, when you have this reabsorption, you can also reabsorb urea. Remember that. But it was something else. No, that's about it. Oh yeah, there is something else. Yes, there is. My brain is like, no, there's something else. The other thing I was going to tell you is that there's these drugs. They call them those potassium sparer type of drugs. Let's look exactly at the mechanism of action because they do work differently. The mnemonic is SEAT. SEAT, like go have a seat. The first 2, SE, are basically spironolactone and eplerenone. Spironolactone and eplerenone. This will actually block aldosterone. So this is going to be an antagonist of aldosterone, these two. Now, amiloride and triamterene also will work with the same kind of action, meaning that the same results, it gives you the same results, but the way that it does this is different. So the action of the inhibition of ENaC and ROMK are going to be achieved differently. Now here you're looking at amiloride. How does this do this? It's able to actually inhibit the ENaC channel. Once you inhibit ENaC, ROMK will also get inhibited. Therefore, you're able to counteract the action of aldosterone. Counteract the action of aldosterone. That's how it works. So understand here that there's two different types of mechanisms of action, but they're both achieving the same type of results. Does that make sense, everyone? Does that make sense? All right. Good. All right. So everyone, let's leave it here. It's 9:30. It's 9:30. It was a really good session. Really great session. We did a little like drill kind of stuff. We kind of reviewed in the beginning. We jumped all over the topics. Then we did some questions. Then we talked about some deeper concepts. We went all out today. I don't even know what to call this session. There was questions. There was like kind of like a drill. There was kind of like a lecture, right? Like we were very much on point. Yeah, and the participation was perfect. I really liked the participation. Everybody had a good idea of what's going on. Definitely, I'm going to post this right away for everybody who missed it, or you can just rewatch it if anything. But yeah, very good session. I like how everybody was interacting, definitely. And yeah, you guys pretty much know your stuff. Guys pretty much knew your stuff. Definitely. So good job for everybody who participated. And next time, raise your hand. We just start participating and do it. So in Patreon, I do this session where I have question sessions. This is basically a class like a question session where we break down questions and we analyze them. It's in the Patreon tier. Today I just gave this free class. I'm probably going to give a couple more free classes this month, but this is just a good example. So I'm going to post this on the Patreon for everybody though. And yeah, so I have that tier available. We also have the $25 tier where we're just basically giving class. So the calendar is packed. Definitely. Thank you everybody for spending the time with me tonight and going through all these concepts. We'll continue, definitely. I do have a camp available. Everybody who's on the camp, we'll see you guys tomorrow. Yeah, we have to continue grinding it out. Tomorrow we have to push hard on renal. We have to finish it up. Thank you. I appreciate it. I appreciate everybody. Thank you so much. But we have to finish up tomorrow. We have nephritic nephrotic on the plate. A lot more pathology now instead of physiology. Perfect. I'll catch everybody tomorrow. Everybody take care. Have a good night, and I'll post this immediately. No editing, nothing. Straight up, just how it came out.